My name is Dorina Bajzát, and I'm working at Hungarian Pediatric Institute as a resident doctor. My vision is good timing and good methods of surgery elevates the quality of life of patients with inflammatory bowel disease. To reach this goal, I would like to assess the current situation of surgical interventions and improve the quality by communicating the results. Intestinal resections are still unavoidable in more than 40% of patients with inflammatory bowel disease. Therefore, we started to investigating these two important questions in the topic. In the first project, we analyzed the association between preoperative anti-TNF-alpha therapy and postoperative complications in pediatric IBD after intestinal resections. Over the past decade, anti-TNF-alpha therapy have revolutionized the treatment of IBD. Nowadays, this is the first-line therapy in moderate to severe IBD. However, according to publications, it increases the risk of infections. Therefore, the use of biologics before surgery is controversial. However, the most recent meta-analysis in the adult population didn't find any differences between the complications in the group of patients who were treated with infliximab or not. In spite of this, the pediatric surgical guidelines still recommend stopping anti-TNF routinely prior to abdominal surgery. So our aim was to assess the safety of preoperative anti-TNF-alpha therapy within the washout period in pediatric IBD. We formulated the research question: is it safe to operate the patient who received anti-TNF therapy within 12 weeks or wait for the washout? The population of the paper was children with IBD and intestinal resection, and we compared those who were treated with preoperative anti-TNF-alpha therapy with those children who didn't require this therapy before the operation, and the outcome was the postoperative complications. We divided the adverse events into two main groups: infectious and non-infectious complications, and we also investigated surgical site infections, readmissions, reoperation, and lengths of hospitalization. This forest plot shows the results of overall complication. As you can see, we have three articles in this forest plot. The odds ratio of the first two articles is lower than 1, while the third odds ratio is higher than 4. Actually, the third article defined the intervention a little different than the first two articles. However, the overall odds ratio is 1.38, which suggests that patients with preoperative anti-TNF have a higher chance for postoperative overall complications. The second forest plot shows the surgical site infections. Here we divided the population into two main groups: patients with Crohn's disease and patients with ulcerative colitis. As you can see, the odds ratio of the Crohn's disease is 1.09, which means that there isn't a significant difference between the two groups, while you can see that the odds ratio of patients with ulcerative colitis is 0.45, which means that patients with preoperative treatment have a lower chance for postoperative surgical site infections. However, the confidence interval crosses the line of null effect, which means that it's not a significant difference. In conclusion, we can say that our results didn't reveal any association between preoperative anti-TNF-alpha therapy and postoperative complications in pediatric IBD. According to our findings, we can say that there is no need to delay the operation because of anti-TNF-alpha. However, a randomized controlled trial with a higher number of cases and more detailed data about the baseline characteristics should be performed with more precise information about the last dose and trough level of anti-TNF-alpha. Fortunately, this January, we can publish these results in the paper called Inflammatory Bowel Disease. In the next part of my presentation, let me introduce my second project about intestinal resections in pediatric Crohn's disease. This is a nationwide survey based on the Hungarian Pediatric IBD Registry. Based on clinical experience, there are some children with Crohn's disease whose CD starts in severe form, and the induction therapy is ineffective. Therefore, they require intestinal resection shortly after diagnosis. Intestinal resections can cause vitamin deficiencies. There is a high chance of further resection, which can easily lead to short bowel syndrome. Moreover, these patients may require stoma. All of this have a major impact on patients' quality of life. So our aim was to characterize this patient population and identify risk factors which associated with early intestinal resection. We used the data from the Hungarian Pediatric IBD Registry, which was launched in 2007. It is an existing prospective and nationwide registry with 27 centers. We formulated the research question, what are the risk factors for early surgery in pediatric inflammatory bowel disease? The population is children diagnosed with Crohn's disease, and we compared those who underwent an intestinal resection within 6 months after diagnosis with those children who didn't require this type of resection within 6 months. The outcome was the risk factors for early surgery. This figure shows the potential risk factors, such as anthropometric data, symptoms, laboratory tests, granuloma, extraintestinal manifestation, diagnostic delay, location, and the pediatric Crohn's disease activity index. First of all, I would like to talk about the descriptive results. As you can see, there were 27 patients in the early resection group, and we found that the mean age and the activity index are higher, while female gender, perianal lesion, and abdominal pain without diarrhea are more common in the early resection group than in the comparison group. After that, we matched the patient who had early intestinal resection with those patients who didn't require these types of operation, and we built a logistic regression model with 4 variables. Based on the odds ratios and p-values, we can conclude that the pediatric Crohn's disease activity index and abdominal pain without diarrhea are the risk factors in this model. We can say, see that the odds ratio of the pediatric Crohn's disease activity index is 1.05, which means if the pediatric activity index increases by 1 unit, the chance of having early surgery increases by 5%. The odds ratio of the abdominal pain without diarrhea is 5.6, which indicates that patients with these symptoms have 5.6 times higher chance for early intestinal resection than patients in the comparison group. Based on our findings, we can say we believe that our findings are important because it increases the awareness, which can result in urgent diagnosis and step-down therapy to prevent early surgery. However, a prospective international study should be performed to follow this patient population. In conclusion, patients with early intestinal resection have a higher activity index and a shorter delay in diagnosis, so we can say they have more rapid and severe disease onset. This slide shows the progress of my second project. Currently, I'm in the manuscript writing phase. This is just a short overview about my 2 projects. Our plan is to submit the second project until the end of August. And some additional activities. I participate in the maintaining of the Hungarian Pediatric IBD Registry, and I had a chance to present my results in these conferences during the last 2 years. Thank you for your kind attention. My favorite quote is, "Never measure the height of a mountain until you have reached the top. Then you will see how low it was."
Good morning, Michael Wolshansky. Sorry, I have a sore throat. Wonderful presentation. The second part of your presentation, though, I'm not sure whether I heard the difference in age, because very early onset IBD tend to have early surgery rather than later. Was that discussed?
Yes, in the second project, we analyzed a patient with Crohn's disease who required early intestinal resection, which means within 6 months after diagnosis. And the mean age was almost 15. And as I remember good, there were 2 patients under the age of 6, so there were just 2 patients with very early onset IBD.
May I ask you questions for the first part and your first presentation? What was the reason for the emergency operation?
Yes, actually...
because this could be a bias.
Yeah, of course it could be a bias. It's a confounding factor, and Some publications mentioned the percentage of the urgency, but most of the paper, what we investigated, didn't say anything about the urgency or the method of the surgery, like was it a laparoscopic or was it an open surgery. But there were a paper which investigated patients with ulcerative colitis, and they mentioned 20% of patients underwent urgent surgery because of some complications, but they didn't say anything about the complications, what was the complication.
And for the second part, it's a registry, and you are speaking about induction therapy which failed. Was it the same in all patients, or were there different induction therapies?
Actually, it was different, but I can say most of the patients were treated with azathioprine, and a high percentage of patients treated with biologic agents before the operation.
So in your first project, you showed us the surgical site infections, and we have seen the effect is not significant. But do you think your overall pool effect is clinically relevant?
Yes, we can see that the odds ratio is 0.63, and as I mentioned earlier, it shows that patients with preoperative Crohn's, with the preoperative anti-TNF therapy have a lower chance for postoperative complications. And actually, it's not statistically significant, but we think it can be clinically relevant. However, it wasn't a statistically significant value.
In your practice, have you managed to persuade the surgeons not to wait?
I have to say it depends on the patient, and it depends on the symptom of the patients and the general condition of the patients. So I cannot say yes or no because it depends on that patient who needs an operation.
On this slide, you have two subgroups, if I see that correctly, and for one, for both of them, if I see correctly, you have three articles. From one of them, you included the prediction interval as well. For the other, you did not. What's the difference there, or how come for one you made this prediction, for the other you didn't?
So your question is about the prediction interval, why we did the prediction, put the prediction interval in the patient with Crohn's disease, and why not in the other group. Actually, it was the suggestion from the statistician, because the prediction interval was really large in patients with ulcerative colitis, and we cannot visualize there, so that was the reason why he suggested not to visualize.
Actually, in connection to this, that in your second subgroup, I mean, there is quite a bit of heterogeneity, I would say. Or I wouldn't say outliers, because two of the studies are actually seem to show some kind of effects while one is not. So is there any reason? So did you figure out that what was the reason for this heterogeneity?
Yes, actually, we didn't find any reason behind the heterogeneity, but as you can see, there are just three articles in the first subgroup and in the second subgroup too, and there were some confounding factors which limitates our results, such as they didn't mention anything about the urgency of the surgery, as I mentioned earlier, the methods of the surgery, or some concomitant medications such as steroids, corticosteroids, and so on. So this can behind this.
Thank you for your presentation. My question would concern your second project. Like, why did you investigate the abdominal pain without diarrhea and not with any other symptoms?
Yes, actually, before we started this project, we had a hypothesis that there is a patient population whose disease starts with mild symptoms, and they just go to the gastroenterologist too late, and the diagnosis is delayed. So we think it can be that symptom, abdominal pain without diarrhea, which is not so bad to go with the symptom to the doctor. So that was the reason why we think we would like to investigate this symptom and not anything else. However, we didn't found that this patient with mild symptoms have a delayed diagnosis. We found that there is a patient population whose disease starts with severe symptoms and with a severe phenotype.
Thank you very much for your nice presentation. I was thinking about the same thing, that if you want to present your results to primary care physicians as well, it might be maybe too frightening to read these results, that
yes.
Especially in children, abdominal pain without diarrhea is, I think it's quite frequent.
A lot of things can cause this.
So maybe it's just a comment, or can be a question as well, how to communicate it to not to overwhelm our patients with these informations.
Yes, that's a very good idea, and thank you so much for your suggestion. I will talk about deeply when I show these results, for example, in a conference, or of course when we will publish these results. I will write a lot about this and behind the reason of why we choose this symptom. Thank you so much.
Can I ask, maybe you can look at calprotectin, fecal calprotectin, and that could be a predictive factor as well?
Yes, actually, nowadays, before the diagnosis or during the process of the diagnosis, we always check the calprotectin. However, in this study, we haven't checked in, or we haven't investigated that value, but in the future we will check because of course it can be a very important risk factor. Thank you for your suggestion.
So thank you very much again for this very nice presentation. My last question is, you have one publication and
yes,
one is
right.
in preparation, which
yes.
will be submitted.
Currently I'm in the manuscript writing phase.
Okay, thank you.
Sorry, I have one comment. I hear several times in your second project that you talked about your odds ratio and you say that chance. Please do not use the chance instead of odds, because it's not the same.
Okay, thank you so much.